We're really excited about this very special rendition of the of our jam sessions today as we get to highlight two awardees of a program that we've really been delighted to have at the center for the past now 5 years. This is the MACCH, or Mid-Atlantic Center for Cardiometabolic Health Investigator Development Corps. And we have a couple of our awardees who I will introduce in a moment who will be sharing their work that they conducted through this program. But just to tell you a little bit about the MACCH IDC, it's led by these colleagues who are noted here, Dr. Tangela Purnell, Dr. Sam Saha, and then myself and Dr. Simeon Taylor. We can go to the next slide. So many of you actually may know that MACCH is an overarching center award that we were fortunate to receive at the Center for Health Equity back in 2021. That comes from the National Institute for Minority Health and Health Disparities, and Dr. Cooper and I are the co-principal investigators of MACCH. And within MACCH as a whole, we have 4 different clinical trials that are underway. Also, though, as a part of the Center Award, we were provided with funding wherein we could provide pilot grants to early career investigators who are conducting health equity research or research that's addressing health disparities. And so to tell you a little bit more about the program, we set this up again to focus on early career investigators who were conducting innovative research related to chronic disease disparities, particularly those that are cardiometabolic in their sort of origin, and also to create a multidisciplinary mentoring network and a community for the project pilot awardees. And so the program has involved mentorship pairing with a member of our investigator development corps, a scholar advisory panel. The scholars have had access to our MACCH data and intervention work groups, and they've also had access to didactic training, including being invited to the jam sessions like this one, as well as to sessions that are held by the network, the broader network that MACCH is a part of, which is the Health Excellence Action Network, or HEAN for short. Over the past 5 years, we've received 62 applications for this MACCH pilot project program that have spanned 8 investigator institutions, and we've awarded 33 pilot projects over the past 5 years. As far as the outcomes, we've had 13 publications that have been completed, again, by those who have already completed their time as awardees, with 1 publication that's pending. Several additional grant awards have been made to MACCH pilot program awardees, and we've continued to have the awardees be able to expand their various presentation opportunities. And we're excited for there to be one today for a couple of the awardees. So next slide. So just to give you a sense of our previous MACCH scholars, so this was our first cohort. You can see that they span multiple institutions, so 3 different institutions, as well as 3 different schools within Johns Hopkins, or our School of Nursing, Public Health, and School of Medicine. And they are working across a number of different topics. You'll see one of our featured speakers today, Dr. Sylvetsky, was a part of that first cohort of MACCH scholars. Next slide. This was our second cohort, again, coming from 3 different institutions. You'll see a big focus on people who are doing work around obesity, people doing work in the kidney disease space, including Dr. Taylor, who is our second featured speaker today. Next slide. And then this is our third cohort. Again, multiple different institutions. Many of you know, I'm sure, lots of the folks featured here. I see Dr. Loddick is on today. And and I'm sure you know others, especially those that are based at Hopkins, who were awarded. And then next slide. And then this was our fourth cohort. Again, here this year, this particular year had a very strong representation from the School of Nursing, and we had awardees who were doing work in addressing uh, maternal health disparities as well as child health disparities, and continuing again with a big footprint around a number of different cardiometabolic health conditions. Next slide. And this is our rapid cycle group of awardees where we funded these individuals who were able to complete a project within less than a 6-month period, because we are in the last several months right now of our primary 5-year award for the overall grant. We are hopeful that we will be able to apply for a renewal of our broader P50 Center Award, with the hope that in the future we will be able to continue to offer pilot grants. I think that's the last slide. Great. Okay. So today we are really excited to have two of our former MACCH pilot awardees with us, and we are going to. We don't want to do anything any differently than what we typically do at jam sessions, so we're going to introduce them the way that we do in our jam sessions, beginning with some fun facts, and then we'll do some formal introductions. And for today, once they finish their presentations, we'll have a little bit more of a kind of a panel style discussion. So first, we're going to start with Dr. Allison Sylvetsky. And Allison offered up a number of fun facts for us. So I want you all to please engage the chat to guess some of the answers to her fun facts. So first, Allison shared with us her favorite form of exercise. So I want you all to guess what her favorite form of exercise is in the chat. Bonus if you find an emoji that aligns with good guesses, good guesses. Okay, well, the correct answer came pretty early. Allison, do you want to tell us how long you've been a runner?
Oh yes, I've been a runner basically my whole life, at least since middle school. But I've only done one marathon, but quite a few halves. So I got to get back into the distance running.
Amazing. Okay. Very good. Well, both of our speakers today are boy moms. And Allison actually has two sons. So in the chat, let's guess the ages of Allison's two sons. This is fun. I actually don't know the answer to this, so I'm excited to see what. Allison, are you seeing? Did
Yeah, I'm
anyone
seeing. I
get it
think a lot
completely
of
right?
a lot of you have the 2-year age gap right, but they're 2 and 4.
2 and 4. Wow. So what's that like?
Total
So,
chaos all the time.
well, we're so happy you were able to make the time to to join us today. So just as a more formal description of actually no, I'm going to do fun. I'm going to go to fun facts for Dr. Taylor. Let's do that, and then we'll come back to we'll do formals right before you all speak. So Dr. Kathryn Taylor. Um, Dr. Taylor uh, has a distinction that is true for only less than 1% of the world's population. Let's go in the chat.
We have somebody with insider knowledge in the chat.
Wow, this is too fast.
Deidre, I didn't know about the 1% statistic.
It's actually 0.4. It's actually really low.
Wow.
Yeah. So, oh, okay. Well, Dr. Loddick is she's she's got extra.
That's so sweet.
She's got extra things. So since it was so quick that it came about, Kathryn, do you want to tell us about your twin?
Yeah, yeah, I am. I'm an identical twin. I'm 13 years, I mean 13 minutes older, so technically she's my little sister. But we look enough alike that we could trade places during April Fools in elementary school, and the teachers didn't know the difference.
That's pretty good.
Did you see we have two other identical
Yeah,
twins
we
in
have
the
two.
audience?
That's
That is
pretty rare.
really unusual.
So,
Yeah.
We're pretty well represented here today.
that's amazing. That is amazing. Okay. And okay, second fun fact. Okay. So Kathryn passed a test to do something that we mostly see in movies with people like Charlize Theron or Bruce Willis starring in. What do you think that is? In the chat. Black belt karate. Okay, this is yeah. All right. Well, I think especially if you combine a couple of these, I think the answer's coming together. Do you want to tell us about the test that you passed?
Yeah, so a couple of years ago, I passed a stunt driving test, which means that I can do like a reverse 360 and I can skid into a parallel parking spot. And it's funny, Deidre, because every time during the class, if you hit a cone, the teacher would tell you that you killed Cameron Diaz. So it was very fun, and only two of us passed, so it was an awesome time.
Wow. Well, we're glad that you stepped away from your rarefied air to to be with us today, because that's pretty amazing. So
It was really fun.
between being a twin and being a stunt driver, that's quite rare. Well, thank you all for playing. We're super excited to have Allison and Kathryn with us, and I'm gonna I think Allison, we're gonna have you go first. Is that okay? Okay. Let me do a more formal introduction of Dr. Allison Sylvetsky. Um, she is a professor and chair of the Department of Nutrition Sciences at the University of Rhode Island, although she lives in another fun fact that we could have chosen from, but she lives in Washington, D.C. She has nearly 15 years of experience leading high-impact cross-disciplinary human nutrition research that's been focused on obesity and diabetes prevention in youth. Her primary interests have been around the consumption, perceptions, and health effects of added sugars and non-nutritive sweeteners. She has got her training at George Washington University and her PhD in nutrition from Emory, and completed a postdoc in diabetes and metabolism at the NIH. Welcome, Allison.
Thank you so much for the introduction. I'm just going to try to share my slides here and see. Okay. Let's see. Can you see it? Not yet. You can see it? Okay. And you can see the full screen, not the, okay, perfect.
Yep, looks good.
All right, great. Well, I'm really excited to be here to present some of our pilot work that we did through the MACCH funding. And today I'll be presenting on our project, Decreasing Children's Sugar Intake Through Pediatricians and Social Marketing, which we abbreviated as DC-SIPS. But I'll also tell you a little bit about a project that we did in parallel, which is the same in design, but it's for little kids. And so we call that one DC-SIPPy, and these are inherently related, so I figured it would make sense to talk about both. So Children's consumption of sugary drinks is a continued public health challenge. Consumption of sugary drinks considerably exceeds public health recommendations, particularly among Black youth from low-income households. And reducing sugary drink intake is particularly challenging for Black youth due to a myriad of psychosocial and economic factors, including food access, related factors, food marketing, limited nutrition education, and food literacy, among other factors. And the reason why we wanted to do this pilot project is because most prior efforts to reduce sugary drink consumption have really overlooked the opportunity to engage families during primary care. And so we wanted to combine engaging families in primary care with social marketing methodology to be able to really kind of create a movement around health behavior change as it relates to sugary drinks and challenge social norms, as has been demonstrated to be successful in other nutrition and health interventions. So the overarching goal of DC-SIPs and DC-SIPI is to leverage the primary care setting and the power of social marketing to decrease sugary drink consumption among Black children and young children living in Washington, D.C. And so for both DC-SIPs and DC-SIPI, they were done in two phases, both of which for DC-SIPs were funded by MACCH. The first involved formative research to really understand this population, understand what the needs were, how to develop materials that would resonate, and to get their feedback on intervention materials and intervention strategies. And then the second part was to pilot test that intervention that we developed using this community-informed approach. And again, we did the same thing for DC-SIPs and DC-SIPI. And for both, we partnered with pediatricians at the ARC, that's a Children's National Affiliated Pediatric Primary Care Clinic in Southeast Washington, D.C., that serves children and families in Ward 7 and 8, and Ward 8 is highlighted there on the slide, which is a historically under-resourced area with a predominantly non-Hispanic Black population. And we also engaged children who were seen at the ARC for DC-SIPs, as well as their parents. And we also then did this second iteration where we focused specifically on parents of young children also seen at the ARC. But for all of this work, we did iterative rounds of in-depth interviews to understand parents and pediatricians' perceptions of sugary drinks, as well as children's perceptions of sugary drinks, and to get their input on strategies to lower consumption, as well as specific types of messaging and information that would change their behavior. And so just first to show you feedback that we received from pediatricians, some of the key themes is that they thought that their colleagues, the other pediatricians' familiarity with sugary drinks and the sustainability of this counseling was a facilitator of the success of this type of intervention. Also, they really liked the idea that we were thinking about using social media and thought this would be a very good way to engage their patient population. I'm not sure what's going on with my slide there. Sorry about that. But they also did pinpoint some barriers, including limited time during patient appointments, and they suggested ways to increase engagement, for example, through using incentives, community champions, and addressing specific concerns in the patient population. And so you can see a few examples of quotes from pediatricians there. Again, really this idea of social media resonated, and then the biggest barrier being the time. And then when it came to children, most children stated that they had received guidance from their pediatrician about reducing sugary drink intake and increasing water intake. So the concept of lowering sugary drinks to improve their diet and health was not new to them. And they did think that having this guidance come from pediatricians would be useful and that their friends would also find this useful. And they had some really great ideas for how to engage their age group and their peers, including challenges with prizes, using reusable water bottles, and then specifically education about the health effects of sugary drinks. And so one example of a quote there is one child explained if their friends knew how much drinking too much sugary drinks affects their body, they would realize it and start drinking more water. And then from parents, again, we used the same process where we did in-depth interviews, and parents were really excited about this concept, specifically around the social media component. And they also had some similar suggestions for engaging themselves and their children, including, again, challenges and incentives, offering examples of unsweetened, healthier beverages, and education around sugary drinks. And then for DC SIPI, where we were specifically focused on young kids, again, some very similar feedback, a lot of enthusiasm, but parents had some suggestions to really target younger children. They were also excited about the idea of having something specific for little kids. As you can see from the quote there, usually, older kids are targeted, but this program helps us moms who also have younger children. They also really like the social media idea and also, had some suggestions about more relevant beverage examples when we shared examples with them that, some of these things they weren't familiar with and didn't think were consumed in their communities. So using this process, again, this was very iterative. We did several rounds of in-depth interviews with these different stakeholder groups. And after we had an idea sort of the concept, then we got more into the content. And so the first kind of content piece that we really wanted to refine was our logo. We had come up with this prototype logo on the left, which you can see there is fairly bland. It was just based on, a bunch of our team at GW at the time, really coming up with ideas. And then after iterative interviews with children, with parents in the target population, ultimately these were refined into more engaging logos that better resonated with the population, but also that retained key elements of the original graphic that the parents and children said resonated, specifically the DC representation. You can see the DC flag there on their water bottle, and also the idea of having a water bottle or a water splash was something that the families said that they really enjoyed. And then we use this same exact process to take prototype graphics and messages that we had developed based on our formative research with this population to then get feedback from these different stakeholder groups and ultimately refine the graphics. And so this is one example, and the reason I like this example is this is one that actually parents really didn't like because they thought it was overwhelming. They didn't think it was funny. They thought it was cheesy. But we developed this because we had heard in our formative research how deceiving claims on packaging are and how people need more education around what's actually in the beverage. And so using the feedback that we got from parents, some of the key themes in these interviews were that parents wanted more actionable information. They wanted to see the back of the label. They wanted to have a real beverage. They did not like the little investigator, for example. And so ultimately with this feedback, we refined the same message, but in a way that resonated with the population. And then through additional interviews, we're able to confirm that this is the type of information that gets the same point across, but that the families really found to be the most useful. And so we went through this same exact process with many, many graphics to ultimately develop 42 of them, one per day for a 6-week intervention. But this was the process that we used for all of these different concepts and all of these different messages. And these messages were not just shown like what you just saw. These were shown as part of social media posts based on the parents' feedback. The parent-focused messages for DC SIPs were on Facebook, and the kid focus based on the kids' feedback were delivered via Instagram. And so you can see here again these graphics that were branded with the DC SIPs or DC SIPI branding and that were created based on the family's input were used along with captions that also resonated with the community to ultimately develop a social media intervention that was again delivered over the 6 weeks and targeted for either the older kids or the younger kids. So ultimately, putting this all together, we developed, as I mentioned, a 6-week intervention. You can see here that they were topically divided into 6 different topics: benefits of water, health risks of sugary drinks, checking the nutrition facts, myth busting, rethinking their drink, and then more sort of long-term strategies for sustainable behavior change. And behind each of these graphics, right, each of these weeks are 7 posts. And they all, again, were using this community engaged approach to develop them and all had a similar structure in terms of, for example, every Monday was goal setting, every Saturday was a swap for a healthier drink. And then based on the feedback that we had received from the kids and the parents, we also provided these DC SIPs branded reusable water bottles that the families have said would be helpful for them. And for DC SIPI, we followed the same process. You can see this looks very similar, but is all branded and really directed for younger kids, but the topics are very similar. And again, the process was the same. And we also gave the families DC SIPI branded toddler water bottles or sippy cups, which they had said would be helpful, along with water pictures, which we also had heard as an area of need, specifically with regard to concerns about tap water safety in Washington, DC. So about a year ago, we published the development of the DC-SIPS intervention, which you can see there in the Journal of Nutrition, Education, and Behavior. And then we also have a publication under review right now that's reporting the development of DC-SIPI. That's been revised twice, so hopefully will be accepted soon. And we're working right now on writing up our pilot findings, which I'll share with you right now from the pilot, the feasibility trial that we did. So in terms of pilot testing, we had families that enrolled in the study, and they attended a baseline visit via Zoom. So it was all done virtually, where we did a baseline assessment of the beverage intake, and then the family started the intervention, which again involved a combination of motivational interviewing as well as social media content. And so they were asked to follow the Instagram or the Facebook, depending on their age, parent versus child. And that way they followed that and were able to see the content that was posted daily for 6 weeks. And then we also mailed them the age-appropriate water bottle or sippy cup. And then they were emailed or texted, depending on their preference, beverage consumption surveys weekly for 6 weeks. And then they came back at the end of the 6 weeks via Zoom for a follow-up visit where we assessed their beverage intake again. And then also did a qualitative interview to understand the acceptability of the intervention from their perspective. So for DC-SIPS, we enrolled 14 families, and the mean age of the children was about 14 years old. The age range was 11 to 17 per inclusion criteria. It was about 2/3 female, 1/3 male. And most of the children, based on self-reported or parent-reported weight, were in the normal or healthy weight category, with about 1/3 of the sample having obesity. And in terms of the findings, it's interesting, but you can see here that, and I think part of this was how we set up the data collection, but you can see here that there was no change in water. There were reductions in sugary drink intake that were significant at, this is in ounces per day, at several of the time points, but not all of them. But what my takeaway from this is that there's a lot of variability. These are really all over the place from week to week. And I think a part of this is because, as mentioned, they did the beverage consumption survey with a research assistant at enrollment and at 6 weeks follow-up. But in the middle weeks, they were being texted or emailed a survey that they did on their own, right? And so I think that may contribute to some of this, but in terms of feasibility, we weren't going to have them come back every week. And so this is sort of when we look at the, all 7 time points, counting enrollment and then 6 weeks, it's really all over the place. And when you just look at enrollment versus a 6-week follow-up, there was a reduction, but not a statistically significant one. So again, a very small sample size, 14 families, and some lower numbers at some of the time points. So I would take this with a grain of salt. But from what we were really interested in for this pilot study was feasibility and acceptability. And what you can see here is that there was high engagement. Participants found DC-SIPS very easy to follow. They appreciated the content and they found the information valuable. They did have some challenges that they described, including really, it was difficult to monitor, especially from the parents' perspectives, their child's sugary drink intake. And it was also difficult to access affordable, healthy drink options, which is part of why we provided the water picture in DC-SIPI, but that was not the case in DC-SIPS. But people did have a very overall positive perception of the program, including higher water intake that they reported, greater awareness of sugar content, and they also said their children were really motivated to engage. And then when it came to the children, participants enjoyed the program, similarly to their parents. They also found the goal setting in the surveys to be quite useful, and they said that they helped them stay on track. And they also reported that the program led them to drink more water, even though our quantitative data didn't actually show that as a statistically significant change. But their perception was that they increased water intake, and they really did like the water bottle, as you can see from this quote here, especially with the water bottle you gave me. I get that, fill it up every day, make sure I drink it by a certain time when I put myself on a schedule. So they were describing some behavioral changes that help them to adhere to the instructions to, drink fewer sugary drinks and drink more water. And then for DC-SIPI, again, this was the one where it was parents of young kids, 1 to 5 was the inclusion range of the age of the children. The mean age of the children was about almost 3 years old, so 2.8. Most of the children in the study, for whatever reason, were female. And you can see there that this was a very low income population, with actually most of the families reporting an income of less than $10,000 annually. And we did confirm this with the clinic because we were pretty surprised by this, and they did verify that that is indeed correct. And so looking at the quantitative results here for DC SIPI, this looks much better than it did for DC SIPs, which is that looking at just baseline versus the 6-week follow-up, there was a statistically significant increase in water of about 4 ounces per day. And there was a significant reduction in sugary drink intake of about 10 ounces per day, which is quite substantial when you think about the age of these kids being only 1 to 5 years old. And you can see that for several of the beverage categories that comprise sugary drinks, like sweetened fruit drinks, sweetened tea, there were also statistically significant reductions in intake. And so we were more encouraged by the findings of DC SIPI than DC SIPs, but again, also quite a small sample size, but more than we had for DC SIPs. And then finally, just to share the qualitative results from the parents in DC SIPI, you can see here that, again, participants reported having a positive experience with the program. They found it enjoyable. They also found having the water filter picture really, really helpful. That came up a lot. And again, that was not provided in DC SIPs. But parents did report some challenges, specifically when it came to increasing their child's water intake, especially when the kids weren't with their parent. It was hard to kind of control their intake, but you can see some examples of the quotes here, specifically for the water picture. It was good to know we have filtered water. Like I'm not sure, like I'm not all quite sure about the water from the tap or from the refrigerator. So I just felt a lot better about using water from the picture and their water bottles. So I think that had the biggest impact. So really kind of encouraging the importance of water filters specifically for this population. So in conclusion, we found that DC SIPs and DC SIPI are feasible and acceptable, and they resulted in some promising decreases in children's sugary drink intake, specifically for the little kids. But with DC SIPs, there was a hint that it may have been going in the right direction. And we also observed that there were increases in water intake among the young children in DC SIPI, which may be in large part due to the water filter picture based on what the parents described. So in terms of the next steps, we'd really like to be able to do this at an efficacy trial, testing both of these interventions in randomized control trials, with the long-term goal of scaling and adapting both of these programs to reach other communities within and beyond Washington, D.C. And given my transition to the University of Rhode Island a couple of months ago, I think Rhode Island would probably be the place where we'd want to start with that. But we also are in the process of adapting this intervention for implementation in other settings, specifically in schools and early childcare. And so a lot of exciting next steps here. We have an R01 that we're writing. Hopefully it gets submitted in October. And then, we'll go from there. But thank you. This has been a wonderful opportunity to be able to do these studies. And I think there's a lot of next steps that we just need to continue to move forward. So a thank you to my mentors and collaborators on the project, several research assistants on this work, one of whom I know is here today. And then, of course, our funding from MACCH, as well as some additional funding we received from GW to be able to do DC SIPI in parallel. So thanks, and I'll look forward to questions.
Thank you so much, Dr. Sylvetsky. That's really wonderful work. We're going to ask everyone to hold your questions until we have Dr. Taylor speak, and then we'll do kind of a panel style discussion here in a bit. But you can see the appreciation coming through. Yep, you can take it.
Yeah, I'm trying.
Thanks. Uh-oh.
Okay.
I hope it works.
Okay. There we go.
Okay. And if Dr. Taylor, if you want to start working on sharing your slides as I do your more formal introduction. So Dr. Kathryn Taylor is an assistant professor at the Johns Hopkins School of Nursing, and she's an early stage investigator, although she had a prior career before entering her current career working for a dialysis provider. But she has been focused on improving health outcomes among people with kidney failure who receive dialysis. And her research examines how contextual and system level factors shape outcomes, with the aim of developing new models of care for people who receive dialysis and live in disinvested communities. And welcome, Dr. Taylor.
Thank you so much. I'm really excited to present findings from my MACCH pilot. I've called this talk, Life is Either You're Going Into a Storm, Going Through a Storm, or Coming Out of One. Insights from young and middle-aged adults receiving dialysis in Baltimore City. So I want to start by sharing a little bit about myself as a positionality statement, a little bit more about kind of who I am and how that shapes the way that I do this research. So first, you can see that I'm a white woman. I grew up in a rural town in Lower Delaware, very close to Rehoboth Beach. But I've spent over half of my life in Baltimore City. And we all know that it's highly segregated here and also vibrant and resilient despite its negative reputation. I met my partner here and we live together in the city with our son. This is Levi. I've been a nurse for over 15 years in a variety of settings, and I have extremely vivid memories of taking care of young adults on dialysis in the hospital. Um, After working in patient safety for a number of years, like Deidre said, I was recruited to become the corporate vice president of quality for Fresenius Kidney Care, where I stayed for about a year and a half before returning to school to get my PhD. So from that vantage point, I learned a lot about large dialysis organizations and individual dialysis facilities, how the stressors in a neighborhood can show up within a facility, and what facilities might do to try to address them. So today I'm going to be talking about racial health inequities and the role of structural racism, but these are less like concepts and more like stories or pictures that I have in my brain as a nurse in my city and as somebody who's seen dialysis from a couple of different angles. I want to start by introducing and connecting you to this population of young and middle-aged adults who receive dialysis. And you'll quickly see why we're focusing on them from the data that I'll share with you. And then I'll spend the bulk of the talk today on findings from the qualitative MACCH pilot. So there are currently about 850,000 people living with kidney failure in the United States. This means that their kidneys no longer function well enough to remove waste products and balance fluid, electrolytes, and acid in the blood. Without treatment, kidney failure is fatal. And though kidney transplant is the gold standard treatment, most people in the United States receive in-center hemodialysis. So that's where somebody attends a dialysis facility, usually 3 times a week, to have their blood pumped through a filter, mimicking the waste removal work of their kidneys. And a smaller proportion of people, about 10%, administer dialysis treatments at home. In the US, adults age 18 to 44 make up 15% of the population of people living with kidney failure. And within that age group, there's almost equal numbers receiving in-center hemodialysis and living with a kidney transplant. So about 60,000 people age 18 to 44 are currently receiving some type of dialysis modality. And I think that this group has been a little bit overlooked because we tend to think of dialysis as something that happens to older people. So I like to point out when we look at life expectancy across age groups, this is the group with the most remaining years of life. We want this group to survive and to receive a kidney transplant. But this is also the group with the widest racial survival inequities. In a large cohort study using data from a national database on kidney disease, Black adults age 18 to 30 had a nearly 2-fold increased risk of dying on dialysis compared to white adults after accounting for differences in kidney transplant rates. And this increased risk of dying continued until age 50. So we have a lot to learn about why this is happening, like concretely what's happening on the ground. We know that because of structural racism and racist policies like historical redlining, Black young and middle-aged adults with kidney failure are more likely than white adults to live in higher poverty neighborhoods. So here you can see that the proportion of adults receiving dialysis who are 18 to 30 and Black increases as the poverty rate of a neighborhood increases. We also know that neighborhood poverty modifies the association between race and survival. In this same study by Tanya Johns, survival on dialysis was worst among young and middle-aged Black adults living in neighborhoods where the poverty rate was greater than or equal to 20%. So we know that there's something in the place or in the social environment that's impacting dialysis survival. And we've done a little bit of work to shed some light on that environment. In a cohort study of about 300 people receiving in-center hemodialysis in Maryland, DC, and Virginia, nearly 60% of younger adults living in the most residentially segregated zip codes reported food insecurity in the previous year. So this means at a minimum, they worried about their food running out or they didn't have enough money to buy balanced meals. And while that information is helpful, there's still this really critical knowledge gap about the lived experience of young and middle-aged adults in disinvested communities who receive dialysis. And so I'm going to use the term disinvested for the rest of the talk because it really captures the active nature of policies that concentrate poverty in neighborhoods with predominantly Black residents. In line with the knowledge gap, these are the objectives of the MACCH pilot. So to explore the lived experience of young and middle-aged adults receiving dialysis and living in disinvested communities in Baltimore City, to identify strengths, needs, and priorities for intervention, and also to engage thought partners for the future design of community-based interventions to address racial health inequities among young and middle-aged adults receiving dialysis. To meet these objectives, we conducted a phenomenological study using narrative interviewing and focus groups, which I'll explain a little bit about now. We used purposive sampling and enrolled people age 18 to 45 who were receiving dialysis at facilities in Baltimore City. And so the dark blue on this map shows neighborhoods in Baltimore City with poverty rates greater than 20%. And the diamonds show the location of different dialysis facilities. So we targeted facilities in those darker blue areas for recruitment. And just as an FYI, the color codes are actually showing the quality of the dialysis facilities, with red diamonds having the lowest quality scores compared to national benchmarks. So we got at lived experience through a type of interview method called narrative interviewing. And it can be a little bit unnerving to do narrative interviews as a researcher because you don't use a structured or even a semi-structured interview guide. The idea is that you're asking somebody to just tell you their story as they see it and not to respond to questions that you've created. And so the participant is really the one driving the interview, telling you the information that they think is important and relevant instead of the researcher. And we scheduled interviews at a time and location of participants' choosing so that they would feel comfortable in the environment. And we wanted to compensate people fairly for their time, so participants received $50 for completing the interviews. And I have to say, they were truly amazing. Some of these interviews lasted for hours. People told us it was the first time that they'd processed their experience on dialysis with somebody and that it was even therapeutic. But one of the challenges of obtaining extremely rich and nuanced and plentiful data is that then you have to analyze it. So we used a data analysis method called reflexive thematic analysis. And like other qualitative data analysis methods, the product of the analysis is a report of overarching themes and codes from the data. So the goal was for the themes to really characterize lived experience and for the codes to help us identify strengths, needs, and those high priority areas for intervention. One of the unique characteristics of reflexive thematic analysis is that themes are created and they're the outcome of the analysis. They don't pre-exist it or emerge from the data. And so validity is really demonstrated through the transparency of the analysis process and the depth of meaning in the themes. The themes should tell the story of the data rather than just describing what the data says on its face. And we had a small team doing data analysis together, but it was really to facilitate conversations about the data rather than to make claims about inter-rater reliability. And lastly, reflexive thematic analysis kind of rejects the idea of data saturation and instead focuses on data adequacy. So you know that you've completed enough interviews when you have meaningful themes that answer your research question. We also used focus groups for member checking where participants could interrogate preliminary themes and codes themselves. We hosted dialysis-friendly dinners, and they gave us feedback about whether the themes and codes reflected their lived experience. And a really amazing trained facilitator shared findings, asked participants to rank the themes and codes that had the greatest impact on their life using a design technique called card sorting. So now I'll share what we found with you. And before I do, I have to say I really love this data. For the sake of time, I'm going to share themes with some exemplar quotes, and it's not going to do the data justice, but I'm just going to have to be okay with that. And some of the quotes that I'll share are a little bit long, including some mild profanity, but I'm going to read them to us. So we interviewed 13 people from late 2023 to the middle of 2024, and these are the sample characteristics. Average age was 38. The youngest participant was 25. Most were men, all self-identified as Black or African American, and all but one identified as non-Hispanic. We enrolled people based on the location of their facility, but we know that people don't always live in the same zip code as their facility. So we looked at the poverty rate of the zip codes where participants lived to see if we were capturing the impact of place. And we found that the average poverty rate of participant zip codes was 21%. So we synthesized and interpreted the data to develop 4 overarching themes. They were life disruptions or loss, sometimes normalized, evolution of a survivor mindset, vulnerability met with abandonment, opportunism, or intimacy, and the work to get tailored resources. So I've shown a few of the codes that make up these themes. For example, in the theme evolution of a survivor mindset, the participants described this process of being stuck in why me thoughts. And some of them were still stuck there. Others talked about their belief that you have to see life the way it is and not the way that you think it should be. They talked about using humor to cope with the monotony and the hopelessness of being on dialysis at a young age, and the importance of staying in the present, to not get overwhelmed, but to still have a goal or a purpose to live for. And these really struck me as the type of shifts in thinking that people have to make in survival situations, which is how they really coalesced into that theme. And overall, we generated 32 codes from the data. So here's an exemplar quote that conveys the theme of life disruptions or loss, sometimes normalized. This person says, I found out, I want to say in 22, that I had diabetes. At one point in time, I was managing it well, but it was a very short amount of time. And then I got shot 5 times, and then I fell off the wagon. A lot of times I couldn't afford health care, especially after my father took me off his health care plan. So most of the time I went to the hospital or got medical attention is when I was feeling off. I know one time I went to a hospital and they said I had a lot of protein in my urine, but that didn't really trigger, hey, your kidneys are failing. So about 2 years went by and then I was struggling. A lot of things were happening at one time. I had to move out of the house that my father owned, which he's no longer living. On top of moving, I got fired from my job. And then the following week, I'm in the hospital because I'm having kidney failure. 2 weeks, 3 weeks there. Now I'm on dialysis. That sucked. So I've highlighted some of the key disruptions, and you'll note that they happen in a really close time frame. This is not unique. This is common across each of the interviews. And you can sense in the way that this person says, that sucked, that these upheavals are really kind of normalized, like SNAFU, if you're familiar with that acronym. This is a quote that I love that supports the code about being stuck in negative thoughts after starting dialysis. This is a phase in the evolution of a survivor mindset that people could stay in for a long time. This person says, the biggest lie that we tell is the one we tell to ourselves. Like once you start convincing yourself, I'll never get out of this situation, never get a transplant, things will never get better for me, I'll never get married and have kids, never have this, never do this, things will never change, America will never love Black people. The more you keep telling yourself these self-deprecating things, this is the lies. And I spent years whipping my own ass like this is bullshit, it's not going to get any better. And I was hanging with people that are using cocaine, going out doing crazy shit. It just didn't make anything better. Many participants actually, after the interviews ended, would tell this sort of after the recording story about a friend or a person they knew from their facility who gave up in this phase and passed away. Participants all described feeling vulnerable financially and sometimes physically. And this person described vulnerability or dependency in both ways. This quote also captures all three possible responses from other people: abandonment, opportunism, or intimacy. They say, I'm past due on a lot of my bills. I don't have nobody to help me, don't have transportation to get from point A to point B. Now here lately, I've been getting mobility, but a lot of times I don't have money to get on mobility. It's like 210. So even with that, I have to call my son. He like, Ma, I told you I don't have it. I'm like, what's going on with your money? And not that I'm in his pockets, but I really do need help. I was in here hungry at one time because I had another young lady staying here and I had to put her out. She took all my food and a bag of my clothes, so I was scrambling to try to find something to eat. They say, well, God is the provider. He provided for me because I was able to find little things here and there. There's a guy who lives across the street in the halfway house or something like that who would come in and help, take the trash out for me, help me up the steps when I got out of dialysis. One day I told him I found some hot dogs in the freezer, so I was going up the street to get some pork and beans, and could he help me up the street? He said he was going to the market, he could get some for me. So he got me the pork and beans, and I was able to eat the hot dogs and beans that night and the next day. So the son doesn't show up the way that this person needs. The young lady steals the person's food, and the stranger comes through unexpectedly. And maybe hot dogs are not what we would want somebody with kidney failure to be eating, but I think this person gives us great insight into the creativity and the emotional work it takes to make a meal. Last, these quotes support codes about financial strain, the social safety net being a double-edged sword, and needing guidance, all within this overarching theme of the work to get tailored resources. So the first one says, it's really not easy at all, always asking to borrow money or something like that. And I don't think these people with disability, I don't think they care. It's like, why does it take a year for you to get all my medical records and stuff like that to see I'm struggling? Why does it take a year? You all throw money at stupid shit all year round, but you're going to make the disabled and sick people wait a year? And the next says, I got kicked out of the house where I was living too at the time because I didn't have no rent and had no money. I wasn't getting disability yet. So I was working part-time on dialysis, not on disability or nothing. Again, I didn't have anybody to guide me like, hey man, you're on dialysis. Let me take you to Social Security. Because I was on my own on the street. I spent a lot of years on the street before I had kidney failure. Multiple participants talked about disability taking too long, disability covering medical costs but being inadequate for other expenses, having to pay back benefits once they started making money, and they have to navigate multiple programs, relationships with physicians and other clinicians, all to get the help, information, or the resources they need to live their right way on dialysis. They felt overwhelmed with information, but still in need of a guide to help them tailor information to their unique situation. And quickly, here are the results from the focus groups. 11 out of 13 participants joined one of 3 focus groups. We scheduled them for 90 minutes, but people stayed for about 3 hours each time, mostly to keep socializing. And overall, codes within the mindset and resources themes were perceived as the highest priorities. Here's a participant who rated financial strain as their highest priority. There was really great discussion about whether mindset or resources was the most important or the most foundational, but they seem to really be interrelated. So if people couldn't move through the shock and the grief and the disbelief of being on dialysis to survival, or if they took it all on themselves, then they wouldn't be able to function or do anything else. But if they didn't have enough money, then that also fed into the mental aspect. In conclusion, this is a really unique and complex group. They've navigated structural disadvantage and some intense hardships over the course of their lives, which is in part what contributed to their kidney failure at an early age. And now they're managing kidney failure and dialysis, balancing the demands of adulthood and midlife, and navigating really intense existential, relational, and financial strain. We heard again that they perceive both mindset and resources as having the greatest impact on their lives. Those were the focus areas that they would have wanted the most support with. And so there are multiple potential evidence-based interventions that could be adapted with this population, including community health worker services, peer support groups, medically tailored meals, and guaranteed income. We have made some progress since the MACCH pilot. Received a National Kidney Foundation Health Equity Community Engagement Award to actually develop a community health worker program through a human-centered design process in partnership with some of the participants from this study, Sisters Together in Reaching, which is a community health organization here in the city, and also local dialysis teams. We partnered with a local business led by a former kidney transplant recipient called Dialysis to the Docs to start hosting in-person peer support groups. And we just received funding for a pilot project led by a Morgan State assistant professor, Dr. David Fakunle, to further develop peer support programming through storytelling, which is his expertise, kind of trauma processing through storytelling. And I fortunate to receive a K-12 award to conduct a pilot of the community health worker program that we developed. So thank you so much to this project and the mentorship. I'll stop sharing too and get ready for any questions folks have.
Well, thank you, Dr. Taylor. Thank you for sharing that. It's really tremendous work, and you can see the love and congratulations coming through in
Thank you.
in the chat there. So I'll ask if we can for our health equity Center for Health Equity team, if we can pin the three of us for a little panel, if we could do that, and we'll certainly invite people either through the chat or if you want to raise your hand to ask questions of Dr. Sylvetsky or Dr. Taylor about their work. I'll start with just a fun question, Dr. Sylvetsky. I'm wondering if your two toddler boys got DC sippy cups in the course of the study.
They actually did. Yeah, they did. There were some leftovers.
Okay.
But yes, and they loved them actually. So I have some pictures of them with like spaghetti sauce covering all the cups, but
Nice.
using them all in spaghetti. Yeah.
Very cool. Great. Any questions?
Can I ask a question?
Yes,
Sorry,
please.
I can't see
Dr.
my
Patel.
hand raising thing. Thank you to both of you. Those were fantastic presentations. Kathryn, I'll say that was fantastic. I'm a big fan of your work. I actually have a question for Dr. Sylvetsky, though, since I don't work in the dialysis, or I work in the dialysis space, and I'll save those questions for a different time. I'm wondering what the impact of social interactions was for the outcomes of DC SIPs and DC SIPI. In particular, I would imagine that a lot of children, including my children, go to a birthday party and then like all bets are off, right? So was there assessment of the reasons that on a week by week basis there may have been variability in the amount of intake of sugary drinks?
Yeah, great question. So that was something that came up in the follow-up interviews that we did after the 6 weeks, where people were saying, it was challenging to not allow them to have juice or something like that. That was for both the older kids and the little kids. But for those types of things where it was a one-off, like a birthday party, right? I mean, that shouldn't have massively impacted the findings over the 6 weeks. So we were really more focused on the everyday type of behavior. And if from the figures, the baseline consumption was extremely high. So they needed to consume at least one a day to be eligible. But we were looking at, young kids that were drinking 36 ounces of sugary drinks a day. So I think, yes, that is, of course, a barrier. But if it was just at a birthday party on one day of the week or something, I would be much less concerned about that. But we also did not systematically, like week to week, assess what the reasons were, just kind of overall at the end of the study.
Great question. Any others? Dr. Cooper.
Yes, very inspiring talks by both of you. I'm feeling so proud and happy to hear about how well you're progressing and what important work you're doing. I have a question for Kathryn. I actually know someone who is a young person on dialysis and has a lot of these same kind of stories. And believe it or not, that person is not even poor. But
Mhm.
you know, I what I was wondering is with the interventions that you are thinking about doing or have gotten some input on, have any of these folks talked about the value of doing things either like remotely or like using sort of digital health? The reason I ask is because I know a lot of them have challenges with transportation, and even if it's not a financial barrier, sometimes it's a medical barrier because if they have diabetes or something else that has affected their vision, they might not even be able to drive. So just wanted to hear your
Mhm.
thoughts about that.
Yeah, I mean, the digital health component hasn't come up as much in the conversations that I've had, except for the idea of doing peer support groups virtually. And so I think the National Kidney Foundation of Maryland and Delaware is doing some support groups in Delaware that are virtual. Um, and so in my mind, I think it'd be great to have a couple of different modalities for those because we also hear that people are feeling very socially isolated.
Mhm,
And so we hosted the meetings on Sundays, which is always an off dialysis day.
mhm,
And it's like a very low stress opportunity for people to get out of their house and socialize.
mhm.
So I definitely think it kind of cuts both ways in terms of like getting people access to programs like that.
Yeah, thanks.
Sure.
Great. Other questions? Looking in the
I
chat as
have one,
well.
Kathryn,
Yes.
this was fantastic. Both the presentations were fantastic. It was such a gift to learn from you both today. And my question is really from a policy perspective, um, just the 1 year of waiting for disability when you're on dialysis, and it's not like that's gonna change. You know what I mean? Like that's not, you know what I mean? And so
Hmm.
do you know of any sort of policy movements to sort of change how people get on disability when they're on dialysis? I'm just curious.
Yeah, I've done a little bit of digging into this and based actually on these findings. And not every state has the 1 year lag, but it actually is a 1 year lag in Maryland due to staffing issues in the Social Security Administration. So I see policy options for sort of changing the way that we refer people to Social Security or having kind of other options. But that delay is kind of baked in because of staffing issues. I would love to see something like a Ryan White type program where, say, like the Kidney Commission in Maryland provides additional resources besides just they pay for certain medications and things, but if they could pay for like childcare, transportation, that would be great as well. Yes. So I think there's other models like in HIV that we could learn from. Um, but it is a very challenging, and not every state has the same delay, but we do.
Yeah, it's interesting. As you raise this question of policy, I wanted to ask Allison, are there, as you know, thinking about your work, are there cities or states where the policies around sugary sweetened beverages seem to be helpful thus far in terms of children's consumption of?
Yeah, so there are several cities in the US that do have sugar sweetened beverage taxes, including several in California, also Philadelphia. And so we do know that sugar sweetened beverage taxes do work to lower sales and consumption of sugary drinks. We don't have a lot of data on the longer term health effects, but yes, that's certainly one policy approach. And then others around, front of package labeling and restrictions in schools or in childcare and things like that are also, other policy strategies that could be considered.
And not in DC though, as
We
far as
don't know,
yeah.
it's been proposed, but we don't have,
Mhm.
there is no, there's not a tax in DC.
Mhm. Great. Other questions for our speakers? Dr. eBay.
Yes. Hi. Um, I wanted to ask you, Dr. Taylor, if you could share a little bit more about your K-12 and your thoughts about the CHW program. And I also wanted to offer, my work focuses on community health workers, so if you'd ever like to meet, I'd be more than happy to do so. But just curious to know what your new project will involve.
I would love to meet with you. Yeah, so part of the work that we did after this MACCH pilot was to develop a community health worker service. So it's having a community health worker screen for social determinants of health and then do some referrals. And so we did a mini pilot of that and learned a little bit more about what people want that service to include, like more relationship building, checking in, even if you don't have updates in terms of like a referral, but just making, being that human connection. And then there's been a couple of pilots in the dialysis space that provide some guidance on how long a community health worker service could last, and how often people should be seen. And so the K-12 is actually focusing on sex differences in hospitalization. So it'd be adapting the community health worker service specifically for women.
Wonderful. I'll follow up with you separately.
Yeah, I'll email you.
Awesome.
You're all working with some of the same friends, so I think it'll be a
Yes.
fast, easy conversation. So that's great. Other questions for our speakers?
Hi, I had a question
Yes.
for Kathryn. So you were saying that, the map that you showed in the darker areas, the it kind of showed the difference in quality between the different sites. How did you determine the quality of the sites?
So the Centers for Medicare and Medicaid Services have scores that they publicize in something called a 5-star program, and you can access the scores through a website. And so it's a score, like a scale of 1 being the worst, 5 being the best, and most people are a 3. But so CMS determines those scores based on a couple of different metrics.
Okay, thank you.
Question. Other questions? Let's keep checking the chat. Dr. Cooper had one in the chat about a family or social network focus might be helpful for young adults as a group intervention, and also
Actually,
for young adults with kidney disease and a group
two-
intervention for youth as far as sugary sweetened beverages.
right, two separate ideas, but actually along the same theme. Like instead of focusing on the individual, maybe sort of broadening it to a family social network kind of approach might be helpful because we know people's peers and their family members have potential to either support them in being
Mm-hmm.
healthier or not. So, a lot of times we focus on the individual, but then there are all these other people that they hang out with all the time. So I just thought just came to my mind.
No, I love that idea. And it's making me think of different stories I've heard about people who feel like their family doesn't understand or they want their family to get more exposure. And I'm also thinking about Threads, which is, like that program in the city that connects young people. I used to go Threads for dialysis kind of thing.
And similarly, Allison, for this sugar sweetened beverages, I thought with the older kids, it might be more about getting them and their peers together, right?
Yes, a lot of peer influence in that age group.
For sure. Well, oh, Dr. Kowalski, another match pilot awardee who's on today. Hi.
Hey,
You had a
yeah, good
question?
to see you. I did. Thank you both for lovely presentations. I had a question for Dr. Sylvetsky, and I apologize. I had to step away at the beginning of the Q&A, so someone also may have already asked this question. But I was wondering, I know you asked folks to sign up on the respective social media channels as a part of the pilot, but I was wondering if you had any information about kind of the dose of messages that folks received, right? Like, are these users who are the type of folks who are on their phones every day, or are they more casual users? And just kind of curious if you had any information about that.
Yeah, that's a great question. So one of the inclusion criterions were that they had to report daily use of social media, the platform that we were using. So we know people were on social media daily, at least based on what they reported to be eligible for the study. But because of the way that, so we had hoped to be able to get all, 20 or however many families in at the same time. That's not how it actually happened in practice. And so we had people kind of going through in waves. And so because of that, we weren't able to use, like, there wasn't a lot of interaction. So we were hoping to be able to measure like shares and commenting and back and forth, but it really wasn't organic in that sense, where the way that we envision it being longer term. This is more of a proof of concept, I would say. So we don't have any quantitative data on that, though we do, have qualitative data where people explained, oh yeah, like I looked forward to the post every day. But certainly, even if people were on social media every day, it's not that they necessarily saw the post every day, right? So yeah, the dosage is certainly a question, and that would be something that we'd have to, more robustly study in a future study.
Gotcha. Thank you for elaborating on that. That makes sense that it would be kind of more rolling, right, in terms of if you were to implement something broader scale. Yeah, thank you.
Thanks. Looking to see if I'm missing anyone. Okay, well, I like Dr. Cooper, I have to say, I do feel tremendously proud. I've gotten to to hear about Dr. Sylvetsky's work for the last few years, and I get to work very closely with Dr. Taylor. So definitely feel super proud of all that you all have accomplished, and certainly looking forward to seeing what is to come. Everyone, please join me again in thanking our two speakers, and uh, we really, I think, are leaving here very inspired by your work, and yeah, just very appreciative of you sharing. And please join us. Is this our last session of the season? I was going to say,
Academic
join us in
year,
the
yes.
fall. So
Yes.
this is our last jam session, yeah, of the academic year. So we will we wish you all a wonderful summer, and we will be reaching out as we get ready for the fall to tell you about what's in store for our jam sessions beginning in September. And Dr. Cooper, did you want to add anything? I don't know to that or.
Just, I think you said it well. Thanks to everybody for, it's been a great year, and it's just wonderful to have such a community of people to share our ideas with and to learn from, and just to continue to support and inspire each other. And yeah, everyone, the academics, the community folks, everyone. We appreciate you. Thanks.
Thanks, everyone.